This is the EMS Research Vlog and Podcast, where we talk about the research-related issues that matter to those who work or study in the area of emergency medical services. Your host is Bram Duffee, who is a paramedic and communications professor.
Welcome to the EMS Research Vlog and Podcast from the studio here in Houston, Texas. I want to start out by drawing your attention to our website where you can check out anything that's show related when you go to professorbram.com. That's professorbram.com. At the website, you can find the latest show, see my talks in the media, order the latest book, and also look at how to participate in research. This is all stuff that can help you grow in the world of EMS research. Like right now, I have a research study open for first responders. So if you don't mind being interviewed by me, then go to my website at professorbram.com and click on the current research tab to apply. So today our guest is Nigel Barr, who's from Australia. He's worked as a senior operations officer, both clinical and education, for Rural Ambulance Victoria. He's discipline lead for paramedicine and urgent care at the University of Sunshine Coast and specializes in EMS infection control. So welcome, Dr. Barr.
Yeah, thanks for having me on today. I really appreciate it. And even though we're so far away, I still feel really connected to North America because I've got a few contacts over there. So it's great to be on. Thank you.
Well, you got my attention pretty quick here. It's just really recent that you put out an article in the May 2024 research project published in the BMC Health Services Research called Paramedics Experiences of Barriers to and Enablers of Responding to Suspected or Confirmed COVID-19 Cases, a qualitative study. It's a long title. I just want to say it again because sometimes when we say titles, they are hard to process. So Paramedics Experiences of Barriers to and Enablers of Responding to Suspected or Confirmed COVID-19 Cases, and you did a qualitative study. Just some of the stuff I wanted to share with the audience about your study is that you took 9 paramedics and interviewed them, and the research question that you used, where you wanted to know what were Queensland Metropolitan Paramedics' experiences, barriers, and enablers, and when they attended to these COVID-19 cases. And so when you talked to them and you took the interview and coded the data, I noticed that there were 26 different codes that you came up with in 5 themes. And so the themes that came out were communication, fear and risk, leadership, work-related, protective factors, and change. And I know that you talked about how during the COVID-19 pandemic, paramedics really faced these unique communication challenges. And it's all because of the mobile nature of their work, right? Because consistent movement between facilities exposed them to varying interpretations of the different guidelines that they had. And then all of this led to inconsistencies and frustration. And all of this just made things difficult for folks. And communication was also complicated by the fact that there was an overwhelming flow of information with the media coverage and misinformation out there. And so paramedics often received incorrect information from dispatch and had to be the one to assess or reassess their own safety before doing things that they normally would find routine. And so these kinds of issues highlighted the need for improvement when it comes to communication strategies. And especially thinking about the experience that end user paramedic is going through. Paramedics had to help patients navigate all of this stuff, and this adventure that we've gone through meant that we've had a lot longer hospital wait times and a shift towards telehealth services. And the physical demands of even wearing the PPE caused discomfort and fatigue, a lot of frustration. And so despite these difficulties, some paramedics were reported a reduced perception of risk and an increased empathy for COVID-19 patients after contacting the virus themselves. So that makes sense as well, that we have so many folks that are going through a nightmare, and then when we get the disease ourselves, we can identify from both sides. And I just really appreciate you looking at this topic, and especially because the person who was in the heat of this, the person that, had to be the bridge between public and the hospitals during this emergency, that was our paramedics. And it wasn't just paramedics in Australia, it was around the world. And so what motivated you to choose this particular aspect or this particular direction when you were studying?
The study was done at a different university, and I was one of the pretty much only registered paramedics who'd done a PhD looking at infection control in all the challenges of in EMS in Australia. There was some work done by other people looking at the area who were nurses and other things, but they weren't actually paramedics. So I was kind of lucky to be in that position that I was exploring this topic. And so the other university, Griffith University, reached out to me saying they've got a master's student and they need some industry supervision on, or not industry, but someone with the knowledge of the industry to help supervise this student through their master's project. And this person was an infection control practitioner, also a paramedic, working for one of the large ambulance services, and was their personal experience through that time that, yes, they had all the numbers, they had all the quantitative surveys that get reduced down to numbers, but the meaning behind the why and how do we improve the experience of people working through a very disruptive time. And we know that pandemics are going to keep happening. We've had SARS, we've had MERS, we've had a whole bunch of respiratory pandemics in the past. Avian flu, bird flus, etc. are they're on the horizon. Probably the next big pandemic to hit. So we know these things are coming, and what we lack, particularly from my PhD, was the I guess the meaning behind it. What are the perceptions and how do we get the workforce to turn up, and how do we keep the workforce safe? How do we keep them non-fearful of what's going on? So how do we look after their mental health during that time? Very stressful time. So when the project landed on my lap, or the invitation, or something, I jumped out and said, I'd love to help look at this question.
Yeah. And so how do you think that I certainly experienced two things. I certainly experienced a very intense time. And I remember I was working 72 hours a week, usually minimum. And one of the things that you mentioned was the fact that different facilities handle things differently, and I think that, one of the frustrations that reading your study brought out in me that reminded me was the fact that, I went through some advanced Ebola training for infection control long before COVID-19. And so I already had some familiarity with how to don and doff, correct PPE and whatnot. But I would go into different facilities and actually be made fun of, right? For wearing a mask, much less, correctly, wearing your gear. And it comes down to, the standard at that place was different than the standard of the place that you are used to being at. And folks just had to have their own standards for, how they were going to protect themselves. And what it comes down to is protecting their families. And so I want to just ask you about, I'm really familiar with the misinformation that happened with the media coverage surrounding this here in the United States. But tell me about how that was, and specifically the media coverage. How did that make things bad in Australia? What kinds of things did that pump up for you all?
Yeah, it was very interesting time. So we had, similar to other countries around the world, we had government mandates. Now, where I lived and worked in Queensland, very different response to what they had in the other end of the country in Victoria. And Victoria had the absolute brunt of COVID. They had the really high transmission rates. They had their workforce shortages a lot more than we did in Queensland. Queensland is a semi-tropical place. The most of the population is dispersed. 50% of our population live outside of a major capital city. And on international terms, our capital city is probably very small, so 2 million people. It does have some high density areas, but we have a lot of medium density and low density population. So the spread of COVID-19 wasn't too bad in Queensland, so we didn't have that many lockdowns, whereas in Victoria, there was things like called rings of steel around the city, so barriers to people moving. There was lockdowns that went on for weeks and months. It was incredibly different in a different state, same country but different experience of the pandemic. But still, the misinformation was out there, and as they hear something on a media site, then they hear a government medical chief officer say one thing, and then a week later it changes when the new knowledge comes through. And I think for people that are not at the forefront of science, don't get that things can change rapidly, and they don't get a risk approach to keep the population safe. So it goes beyond just the individual, your individual choices, having choices removed. And I think this is added to the frustration that, and things could change on a daily basis. So at the start of the day, you're doing one thing, then all of a sudden during your shift, you get a message, oh no, we've got to stop doing that, we're now doing this. And that message takes a long time to filter through. So if you've got people doing different things, and as you said before, different hospitals doing different things, they're making decisions off the same information, but they're making different decisions about how they will respond. And this just led into the milieu of confusion. And then you have your people pushing their political barrows, anti-vaccination or what have you, or around freedom of movement, who also threw a lot of non-science into the equation and totally confused the public. And this was the whole issue. So as you probably experienced yourself, you turn up to cases and the public would have a very different expectation to what your expectation of what's going to happen.
Yeah.
So,
well, it's refreshing to know that it was really similar to what we experienced in the United States. I don't know about you, but I had folks early on come up to me because I was in my paramedic uniform, and they would say things to me like, have you actually had any COVID patients? Do you know if it's really real? And I'm like, yeah, just about 15 minutes ago, but, and then, just a lot of, I think that it's wild to me, because I think that I was sort of thinking that this was just an American experience, right? I thought that this was just like the reaction of, how we are in the United States because of, we like to talk about freedom of speech and those kinds of things in sort of an elevated way. And so those things really pushed on what we faced. And so I think these mixed messages were a big deal. And like you mentioned, sometimes mid-shift we'd have changes. And I'm glad to hear that was them too. I had a partner who had a beard, and he found out in the middle of his shift with me he couldn't have a beard anymore. It made sense to me, but the rules change because we understand the concerns differently at different times. Well, how about so that was the media? How about leadership? How about when it came to how leadership made things better or worse because of these kinds of things?
Yeah, that's an interesting one. Is the leadership around it changed during the pandemic, or as in the approach of leadership changed, and you could see it in the way messages were conducted. First of all, there was message. Then they realized that was just freaking people out, so they pull back their messaging and change their strategy of approach. And the leadership were trying to keep people safe first, but in doing so, some of the messaging made people more fearful. Then they realized, we have to build trust. So every time a mistake was made or a change was suddenly made, people lost trust. So then they went through a trust building sort of exercise with everyone. But at the end of the day, they still had to manage. So leadership on two different levels. Leadership management, you can tease those apart. There were champions in the workplace that helped keep the motivation up, good practice, etc. and then there was the management of it. But the leadership in some aspects was good when they fought for, getting extra time off if you did get COVID without loss of pay, because you did probably contracted through work because you were in lockdowns. So yeah, it was a mixed bag with leadership.
Yeah, because they're in the middle of a strange position, I think, like, right? Because they're hearing one thing from their medical director, a different thing from the government, a different thing from gosh, there's just a lot of different people that are getting information. So based on what you were able to do so far on this topic in your research, how do you envision the findings that you've got and sort of these impressions that you've been able to share that people have had? How is this going to influence maybe policies or practices in EMS later on when we have our next pandemic?
Yeah, it's that question is super interesting because I think there's a few aspects to it. From my original research about the challenges of EMS, I interviewed some chiefs of Canadian services, and the message I got from them, and this was back in 2012, 13, so long before this COVID one came through, and that was about their pandemic experience around SARS and other things. What they're saying was, if we institute into normal practice the things we need to do during a pandemic, we won't have any problems. And then I think that's a big shift in the leadership now is they realize we need to actually do a lot of infection prevention and control as normal practice. And we need to teach that well. We need to get that into our policy settings. We need to get that into a culture. And that then becomes protective. So, when it suddenly came along that you've got to wear a P2 mask, everyone's going, what are these things? How do we fit them properly? People were used to surgical masks. They weren't used to P2s. P2s were something that was known about, never practiced with, never played with. We didn't do fit testing. So now we do fit testing every year. And because your face changes, we take things out of hospitals and expect them to work in the world of paramedics. So take PPE. Half of Queensland's tropical, go all the way down to the bottom of Australia. It's into Tasmania, and it's very, very cold winters, and the summers aren't really humid. They're dry, but they're not really humid. The people in the tropics need totally different PPE to what they do in the other end of the country. So no one's done research on that. No one's done research on, well, how does wearing a mask in a tropical, mostly outdoors type job affect your skin, affect your health, etc. How hands in gloves all day, etc. All these effects. Does that mean people will turn up to work? So there's a lot of research that needs to be done about the way we do things in EMS, because, as you said before, we're a non-static health service. The cases we go to are non-scheduled, so you can't plan on my next case is going to be a COVID case or whatever, or chest pain or what have you. So we need to. The lessons we've learned is, how do we improve self-efficacy of our paramedics, so their belief they can practice safely and well in all conditions? How do we improve the self-efficacy of the public, so when another pandemic rolls along, they know that things are going to change and they know how to navigate the health system? Because there was all those issues around, do I call an ambulance? Do I not call an ambulance? So at the very beginning of the COVID-19, EMS cases dropped. And I know the same thing happened in the US, because I was doing some research with some people over there looking at student experience during the beginning of COVID-19, and the cases dropped by, I think, from memory, around about 30%. So the people were fearful about calling for a health service and going to hospital. I mean, that's just insane. So there's a lot of preparation we can do for that. So that's going to change policy settings. That's going to change training information. That's going to change our public health approach. So you've got all these parts that, if we do well in a non-pandemic environment, they're just going to roll over into a pandemic. So I think it's actually acknowledging that our standard practice has to be better or different to what it currently is. And I think that's a big message.
I teach health communication, and my students and I were talking about this topic the other day, and I wonder, I really wonder what it's going to be like this next go around, because I don't know about it in Australia, but certainly in the United States, there are a lot of deniers. I am so surprised that there are folks that work in healthcare that don't understand or believe in vaccination, that's one thing. But I still know that that there are lots of providers who don't believe in masks, and that's a scary thing because, you know, if I am partners with someone who doesn't believe in that, well, that's great. Now I'm going to be breathing your air in that close space the whole time. So what am I supposed to do? You know, like, um, protect myself from you all the time too. It's like, you know, pretty intense. So because the National Health Service, you know, for EMS is set up in Australia so that it's ran by the government. What happens to a paramedic who has these outlandish beliefs that says things like masks don't work? I don't believe in that. I mean, how would someone like that be approached or handled there?
Uh, yeah, it's you're right. There's we have this universal health type arrangement in Australia mostly. There is private, but there's not really private in the emergency medical setting yet. So there are jurisdictional ambulance services. The government has a position. So the vaccine mandate came in. Let's take it from that angle. If you weren't vaccinated, you weren't going to be working clinically. So these people were stood down. With mask wearing, etc., under OH&S laws within Australia, it's an offence not to comply with a lawful safety instruction from your employer. And so if mask wearing became an issue during the pandemic, then people were stood down. So it quite brutal, but it was also, at the end of the day, the organisations are responsible for their workers' health, and the science comes down on the side of wearing masks in particular situations, particularly with aerosols or droplet spread of infection. So it's tackled, like, initially through education and re-education and explaining why these things are important, putting people through fit tests, making sure they had the correct mask, all those sorts of pieces with the education that went along with it, having champions within the workplace to drive the culture of respiratory etiquette and safety. And then at the end of the day, if things weren't going particularly swimmingly and you had a person that just would not comply, then they were processed through the way of they stood down from duty or found other duties that weren't clinical.
You know, another topic that this spurs on my head is that, you know, there's a big debate in the United States about just how much education does a paramedic need to be a good paramedic to appropriately do the job. And I know that there is a big, you know, education difference in Australia versus the US. And I'm sad to say that our infection control training is very small. And I don't know that it's necessarily part of the standard curriculum in any kind of big way. And so I wanted to ask, were you all caught off guard by that as well? Was the training deficient in Australia like it was here in that area?
Yeah, that's something that's been changing probably for the last 10 to 15 years. If I can just go on a bit of a journey with you with this. At the start of my PhD, looking at the challenges, one of the services said, we have one person. They're a team of one in a service of 3,000 paramedics trying to do infection control. So all they were reduced to was reporting incidents of blood and body fluid exposure and making sure everyone had their flu jab. So that was their job. Since those days, we've got a commission in Australia that's around safety and quality in healthcare. It applies to public hospitals and private hospitals only, but now that's extending into applying towards ambulance services. Along with that change in the National Commission for National Quality and Safety in healthcare, paramedics in Australia became registered under our registering body under a national law, which is designed around patient safety, called AHPRA. Paramedicine Board under AHPRA have a set of capabilities for paramedics. Infection control is in the capabilities, so we have to teach it. There's no way we can ignore not teaching it. So when each university is accredited for their degree programs, they have to show that infection control is taught and taught to a particular standard. So those changes have all come in the last sort of 10 to 15 years. The the accreditation of ambulance services hasn't started yet. It's in draft mode at the moment. It will happen in the next few years. All these things have healthcare acquired infection is one of the standards that they're accredited against. So again, infection control is definitely in their governance, and that governance of infection control is there as well. But most of the workforce is older than being 10 years in the job, or a large proportion is. I don't know the exact proportion. They're the people that are caught off guard. They're the people that the world's changing around them. They haven't necessarily done some extra study. They haven't. They're very good at their clinical protocols. They're used to, but when you get the change, they haven't necessarily been equipped, and that's why each service, I think, has responsibility to keep rolling out training. And when you're going and looking ahead, what do we learn from this? How are our workforce unprepared for the pandemic? How do we prepare them for the next one? Because it's going to happen again.
I think this is a great topic because so much of COVID and talk about COVID has this strange air of politics to it. And what we're doing in this qualitative research realm is just bringing reality, to light. And that's why I want to mention that, in this next segment with Dr. Barr, how I did present a research at a conference last year, and then it was later published in a special edition of the Journal of Paramedicine and Emergency Response called COVID-19 and Paramedic Response: Over-Categorization Concerns in Respiratory Patients. And just like with Dr. Barr's article, I'll read it again because these titles, how every word means something. So COVID-19 and Paramedic Response: Over-Categorization Concerns in Respiratory Patients. And I wanted to bring this up now in this show because I think it covers a different aspect to the paramedic experience during COVID. Your research study asked what were the Queensland Metropolitan Paramedics' experiences of barriers to and enablers of attending suspected or confirmed COVID-19 cases. And I think the benefit is that you threw a large net with the research questions to help understand the true experience of the paramedic. And it shows off their frustrations and their obstacles during that time. And I think that my study throws a smaller net, just a little bit different, because I looked at just one part of the paramedic response. And so for my research question, I asked, how were respiratory patients treated any different before COVID-19 versus during the pandemic? And one of the big concerns is that every patient with a respiratory distress kind of thing doesn't necessarily have COVID, but during a pandemic, we might make assumptions when it comes to our differential diagnosis, because if we're thinking about COVID and we see a respiratory patient, then gosh, and after interviewing 10 paramedics around the United States, I coded their responses for themes. And what I found is that the majority of the paramedics that we're talking about this topic, we're saying, hey, we are over categorizing patients as all having COVID-19. So they were admitting to making assumptions in how they approach these patients. And the participants acknowledged that they use stethoscopes less often and avoided treatments like nebulized nebs for albuterol because it's a confined space and they're worried about infection. And so I know that there are different, realities and different takes to be about making these situations better. But gosh, I know that you and I did different studies, but I'm just wondering, did any of your participants talk about how they care for respiratory patients? Did any of this kind of stuff come up in the folks that you talked to also?
It did come up there. They did acknowledge the change in approach and disposition when they came to these cases. And again, it comes back to the way we do things clinically. If we used meter-dosed inhalers with spacers rather than nebulizing everyone, that the science shows that unless you've got a severe bronchospasm, etc., they can be just as effective, more costly, but just as effective. So it's kind of the way we do things. And along comes, your PCR testing and other things during the COVID pandemic, and self-efficacy of the public testing themselves before, have you done a COVID-19 test? So we can get those things out as part of the response, making those free to the public rather than being costly. And that happened during the pandemic. So these things were very costly to begin with. Then a number were released to the public, so they had them at home. It's all those little pieces that add up to try and drive a standard approach, so people's disposition doesn't. So they're not trying to make assumptions. So they're trying not to work out what is the best approach and safe approach. As you said before, it's about, I don't want to get sick and I don't want to take this home to my family. We go to work to live. We don't live. Well, I don't live to work. I go to work so I can pay the bills. And that's the same as pretty much every paramedic. I mean, we love our jobs, don't get me wrong, but we don't want to bring things home to the family. We don't want to spread disease. And that's why people are cutting the corners and changing their disposition. And what we found is once they contracted themselves, their disposition changed. They were doing things they considered really more risky to begin with. So, and again, I mean, that's an individual safety decision, but do we have the work system and with the different types of studies? Yes, we over triaged. How do we avoid over triaging? And those things certainly happened here. How do we change the way we do things, the way we collect the information, the way we teach the public to actually make it a smoother application of skills for our paramedics, so they don't have to make these assumptions. And I think that's the difference in different research. And as you said, casting there, we've got different types of studies to bring up different answers. We can look at the numbers and go, yes, we did do this, but then the meaning of why did we do that? So going back and interviewing those people, okay, why did you make those decisions? Why did you cut those corners? What's deficient in our policy or our approach? That's the only way you're going to learn the true meaning behind the numbers. Numbers are great if you're testing a theory. Numbers are not great if you're trying to generate a theory. You need to do the interviews and do the hard work, which coding and theming and interviewing is particularly hard work.
I teach a research methods class, and that's why I think about these different approaches to how we're doing qualitative research. You and I definitely had different research questions, but we're like stabbing at the experience of the paramedic, and so it makes me think about, what does this mean for qualitative research? Just what you were referring to. And gosh, does this show that it's necessity? And I think that the answer is yes.
I just think research in EMS is super important, and anything we can do as an individual, as a company, as a health organization, government, whatever it is, we should be trying to support the capacity of paramedics to do research. We should have the control over our own discipline and not be just taking things from, this is medical research out of an emergency department, this is nursing research out of this environment. We should be doing our own research. We should be investigating our own problems. And because if we take research from another discipline, another area, another setting, it's always going to be a square peg, round hole. We have to test those outcomes in our own environment. We have to find out what works, what doesn't work. So you take that problem of different health services doing different things, that makes our life a lot harder. So what do we do as a discipline, as an organization, an EMS organization, or as a professional institute? We have the Australasian College of Paramedicine, the Council of Deans. What do we do as an institution to go, this doesn't work? How do we fix these problems? Transporting one patient from one institution to a higher level of care at another, different protocols, different requirements. You might not even get in during a pandemic. You might not even get through the door. So therefore, you end up transporting the patient back, or you're stuck with the patient. So all those little nitty gritty things which bring a service to a halt and frustrate people. But how as a discipline do we create the noise and get the data and the science behind us to make change? And I think that's the big thing here. EMS research is on the rise. Paramedics doing the research is really important, rather than having doctors and nurses do the research for us. It's really important that we own it. And I just encourage everyone to take an interest and jump in.
Right, because they don't get the nuances, right? It's difficult to take an outsider who doesn't understand the environment the same way. And I really appreciate you and your talk about that, because I am a big proponent of that, so much so that that's the title of our show, EMS Research. Here in the United States, EMS research is just in its infancy. And part of the reason is just because of the education requirements. And here in the US, it's very much that paramedics have just been seen as technicians. And that's very much not the case nowadays, as we have increased our ability to make diagnoses in the field and to treat critical conditions. So this is all part of us growing. And so thank you for being here today. And thank you for helping EMS research.
No, it's been a pleasure. Really enjoyed the experience. So thank you.
Like many of you, I'm also an EMS instructor, so I know what it's like to have topics that are important to cover, but are not actually in your curriculum. So when it comes to EMS research, I want you to know that I've been joining EMS classes lately in a virtual kind of way. It's fun for me to meet your students and talk about EMS research, or even talk about how things are done differently where I am versus where you are. So if you're an EMS instructor like me and you want to give your students a flair of what EMS research is all about, just fill out the inquiry form on my website at professorbram.com. This is professorbram.com, and I'll be in touch. I want to also invite you to check out my latest book. I co-authored it with Four Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis.
We've got to look at each individual patient as a human being who is in need. And we've got to know that when we're in need, we do look to others, no matter how self-reliant we are. If we are in a situation that we've never encountered before, that self-reliance begins to seek, is there anyone that can help me with this situation? I mean, you've used a pretty drastic example with the arm cut off, but I don't care how much skill you have. There's very few people who would be able to not say, "Oh my gosh, I need help," and then all of a sudden someone shows up
with a badge.
Yeah, and you think, well, maybe this is someone that can help. Well, you said that, and I said that, during the first hour of trauma, people are essentially in a state of what we now know is hypnosis state.
I want to invite you to check it out, because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of the properties found in hypnosis. The book works to change the way we approach and interact with any emergency patient who's in acute distress, and it can help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. Follow a link there below to find it, or you could get it almost anywhere books are sold. And if you contact me, I would be happy to mail you an autograph sticker designed to be put into the jacket cover.
Hi, I'm Will Chaplow from the International Pre-Hospital Medicine Institute. You might know about us because of the literature reviews that we post every month, free for your review on our website at iphmi.com, and also published through GEMS Online Magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference, whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field, or what we should be doing in the field, or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here, and all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes & Noble, wherever you get your ebooks, for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials, relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon.
I'm doing a research project related to first responders who live in the United States, and I could use your help if you don't mind being interviewed over a video call. Go to my website and fill out the form. It's at professorbram.com, professorbram.com. I just want to thank you for listening, and I look forward to sharing more insights with you in the next episode. If you enjoy EMS research, please tell your friends and like, share, and subscribe to help others get the message.